We started off the year, I would say, one might say, politically not so auspiciously. The Trump administration greeted the new session of Congress with a 35-day partial shutdown of federal agencies. So, we closed the museums. We had trash building up in national parks, and then this is the National Mall. But it actually had one other side effect that has been a little noticed, and that is that actually we had a little spate of deregulation here. That was accidental, but at least briefly, this period of time was the least regulatory period in modern history. So what did we see? Now this is, the 1st through the 18th was clearly in the center of the shutdown, and there were no proposed rules. So no new proposals to regulate something, and this, it's not just healthcare, it's everything, during at least those 18 days. And there were 10 new final rules, but the reason they came out was they were actually already ready. So they were just being published in the Federal Register. It wasn't that work was actually being done on them, at least in those agencies. There were other agencies that weren't affected, and they probably contributed to the rule count. But also, interestingly, during this almost 3-week period, if you believe the Federal Register numbers, which I wouldn't recommend, then you would argue that we actually saved $6.3 million from the regulatory actions or inactions of that period. This is the keeper right here. This is the only time that we've had a one-page Federal Register. It'll be the last time. Okay, so the ongoing battle over the ACA, some people I think would argue that it's the product of the gang that couldn't shoot straight, but on the other hand, maybe it's silver loading. You're all too young to know this? Well, again, plastic surgery is not going to help that aspect of it. So I think silver loading is the story, and it has to do with the structure of the premium subsidies in the ACA. So what have we seen? We've seen that the unsubsidized enrollees are the ones that are dropping out. And this shouldn't come as much of a surprise. Essentially, if you were receiving a premium subsidy on the exchanges and you were willing to buy the first year, then as long as you paid a little bit of attention from year to year to make sure that you stayed with the second lowest cost silver plan, your premiums wouldn't go up. If premiums increased, that drove up the subsidy because the subsidy was tied to the cost of the second lowest cost silver plan. So the people who stayed or the people who got in the first place, probably a little bit of growth in coverage over the years as people who were eligible for premium subsidies began to understand what that coverage was all about. But the people who dropped out were essentially lower middle class people who were not eligible for the subsidy, did not have good coverage through an employer, probably didn't have any offer of coverage from an employer by and large. And the premiums, they were paying the full shot. Government was not sharing in those costs. And so those are the ones that we're seeing drop out. I mean, it's quite stark to see the change in the unsubsidized share, particularly from 2017 to 2018. That's, by the way, it's not percent, that's percentage points, but 11 percentage point drop in the share of enrollment for people who are unsubsidized is a pretty gigantic drop. And it's even more so when you look at the changes here in enrollment, the specific changes. So overall, the total individual market, this is a Kaiser Family Foundation estimate based on government numbers. But we had a 2 million person drop in enrollment in the total individual market. We actually saw an increase in the number of people in the subsidized exchange market. We saw a decline in the exchange market that wasn't subsidized, but we saw a big drop in the off-exchange market. It's entirely possible that some of those people who fell off the coverage on the exchange or the off-exchange market, the individual market, they may have gotten a good job and they may have gotten employer coverage. That's entirely possible. But it's highly likely that many of them became uninsured. And it's I think, very much because of, again, the cleverness of the subsidy structure and the fact that when premiums go up, in most states now, the first year didn't happen quite this way, but when premiums go up, they go up for silver plans, and that tends to drive up the subsidies for people who are receiving subsidies, who then either shift to a bronze plan for a much lower premium, or in many cases, shift to a gold plan, which has reasonable deductibles, not $5,000 like you see in silver plans, but at very reasonable premiums net of the subsidy. But if you're not getting subsidized, you're not buying a gold plan. Okay, so now, the action that the administration is attempting to take, I think, is a legitimate question. How much of this is about more affordable insurance? How much of it is to provide an insurance safety net to these people who are forced out of the market versus undercutting the ACA? Well, I would say that not much has happened so far. These are the dates for the major final rules for association health plans, short-term limited duration plans, which are no longer short-term or limited duration. It is interesting to me that in the same rule that addressed these short-term plans, CMS said, we would really like it if insurance companies didn't just load up the premiums on silver plans. But they didn't exactly say, well, how would you deal with that? And the answer is that it's up to the states, because the states are the ones that approve plans that are sold on the individual market. So they have the authority to deal with that if they wish to, but all the states said, no, let's go silver loading. Let's maximize federal subsidies. And turning that around is, I think, a political puzzle and a financial, probably a bigger financial puzzle. I would only mention briefly the Texas lawsuit here at the bottom here. The U.S. District Court declared the ACA unconstitutional because the penalty for the mandate was taken off the books by Congress, by a Republican Congress. That's a little puzzling. Maybe there's a legal argument for this, but I would say that if Congress wanted to abolish the ACA, they could have done that. What it abolished was the penalty on the mandate, and so if it actually gets to the Supreme Court, I think that'll be the end of that argument. But in any event, sabotage didn't work. If this was the goal of the Trump administration, it clearly didn't work. Here are the things that have happened over the last year or two. Shorter open enrollment period, less funds for promotional activities. Everybody knows about the cost-sharing reduction payments being suspended, which led to the silver loading. And that's not going to change at least until 2020, if not later. And then the repeal of the mandate penalty. And in spite of all those evil acts, the exchange market is pretty much as solid as it ever was. It's very interesting that the premium increase this year was only 2.8% on average over the nation. By the way, this comes from Charles Gaba, who is, I think, a more reliable keeper of these numbers than anybody else in the country, including the government. So I kind of trust these numbers. Why only 2.8% this year? It's because essentially nothing changed. None of the policies changed. Everything in terms of rules were stabilized, and the plans also by now had a very good idea of who their customers were because they're the customers they had last year. So they basically knew what the costs were going to be. In spite of that, we still had a loss of 400,000 enrollment from 18 to 19, and what that says is that it's the people who are not getting premium subsidies who can't afford that coverage. Okay, now let's go to the war on drugs, but not that one. Let's go to the war on drug prices. you know, what everybody says is true. Yes, list prices have really risen very rapidly over time. You know, in the last 5 or 6 years especially, but nonetheless, the whole history really says that list prices for drugs, for brand name drugs, have been rising very, very rapidly for a long time. That's absolutely true. We see the insulin example. So why are we focusing on this? Well, partly it's because everybody knows somebody who has diabetes or they have diabetes themselves. So insulin in particular is a very sensitive topic because people are aware of the issue. They know what diabetes means. They know how important this drug is. And most people now realize that it's an extremely old drug. I think it's about maybe 80 or 100 years old. So the question always is, well, why is this? But that, I think, is what's driving the political rhetoric in Washington, and this particular drug is I think, a large part of it. However, we should not forget that there is the whole rest of the health sector. And so this is from the National Health Expenditure data, and I forget what year it is, but it's a recent year. This chart never changes. Prescription drugs, now this is retail prescription drugs. Most people don't seem to understand that the actuaries only collect information on retail spending. Retail prescription drugs is about 10% of total healthcare spending. Hospitals have been and still are the major place where we put our money in healthcare for obvious reasons. That's 33%, and you see the rest of this. And then here's an estimate from Alterum Institute, which tries to also add in the share of drugs that is non-retail. If you're familiar with Medicare, that's Part B drugs. These are drugs typically administered in the hospital or administered at a physician's office. And you can see a couple of things about this. One is that even when you add that in, you get 14% of national health expenditures. The other thing you see is somewhat misleading, and this is sort of a lesson, I think, in all economic projections and healthcare projections. You see that the trend is basically pretty flat. It drifts up. Well, why is that? It's because nobody knows what the next price disruption is going to be. Now, I don't mean necessarily an innovation, but nobody knows, in the case of drugs, nobody knows when we're going to get a new spate of biologics that are very expensive, that really work, and that a very large segment of the market needs and will get. I mean, there's a question of what's going to be introduced and then what will be covered and then how many patients will actually receive the product. These are all questions. When you're making a projection, you don't know the answer to any of that for drugs or for anything else. So don't believe projections, other than from Jim Glassman. Okay, so let's quickly move to the Republican plan for dealing with drugs. And is this a Republican plan? I had asked myself when I looked at it, I'm not so sure. This is a plan that promotes competition and controls price. I can't imagine anything more Republican than that. So, you know, there are numerous policies, but here are a few highlights. On the one hand, you know, through the FDA, there's an attempt to do a better job of promoting the introduction of generic products and biosimilars, which are, you know, sort of the equivalent idea for a complex molecule pharmaceuticals. But on the other hand, FDA was set up a working group on drug importation, and Donald Trump just yesterday, or was it the day before, Dean told me, was on the phone with the Florida governor, who said that the Florida governor said he was going to have a drug importation plan for Florida. I'm thinking, where, from Cuba? But apparently Donald Trump said, great idea. Okay, we'll see how that goes. Allowing Medicare plans to manage drug costs, that's kind of a pro-competitive idea. The idea of step therapy, modifying protected classes, that sort of fits in with what you would expect. Would be sort of a market forces idea for Part D, D as in dog, drugs. On the other hand, you have the International Price Index, which is pure price fixing. I mean, heck, do you need to go to the International Price Index to set prices? We don't do that for physicians. I mean, we have some other cockamamie system, but we don't have to go to Germany to find out what to pay docs. We can overpay anybody on our own. Don't take that the wrong way. And then shifting rebates to consumers. I mean, this is a very populist idea until you look at the numbers. And I guess that's probably the slide after this one. Anyway, a few comments about the International Price Index and what's called the Competitive Access Program. And this is kind of, I'm sort of filling in some blanks that I think Wendell sort of opened up. Just to explain a couple of things about how Part B drug payment works. So right now, think of it as physician offices, but it could also be hospitals, hospital outpatient departments, and so on. So a physician who needs to administer, say, a drug for cancer treatment, that's something that has to be done through infusion, or at least it needs medical supervision because it's a risky medical proposition. So it has to be done in the doctor's office. What we do now in Medicare is that the physician purchases the drugs that he prescribes to the patient and administers to the patient, and is reimbursed according to the average sales price for that specific product, plus 6%. So one of the obvious issues here is that if you're getting paid an add-on that is a percentage of the price, the average sales price, then you're probably inclined to go for the more expensive drug with a higher average sales price because 6% of a higher number is more net to you. So one of the ideas that people have talked about is to shift to a fixed add-on payment, which removes that incentive, but doesn't necessarily resolve the issue because where does the average sales price come from? It's very, very complicated, but nonetheless, it's a little bit moving in a sensible direction, I think. The proposal from the administration is to say that we're going to set up these vendors for Part B who are going to be intermediaries. You could almost call them, what's that term? PBMs. And the PBMs, who actually do exist, so I think that it's not out of the realm of possibility that this could get off the ground. It depends on the money, but whoever said that in healthcare. The PBMs would essentially negotiate on behalf of numerous providers of Part B drugs, physicians, hospitals, and so on. It's the usual theory of markets that if you aggregate demand so that you're negotiating for a large share of the market, that you're liable to get a lower price. That's the theory in any event. Can it get off the ground? I think what's going to probably be the problem is using the International Price Index as the reference price for these vendors. So I think what might kill this idea, there are lots of ways you could kill it, but the way that you might kill it politically is to attach something that to Republicans will sound like a market-based solution to something that is price fixing, and it's the kind of price fixing they really don't like because Republicans were involved with the physician fee schedule too. What they really don't like is having to go overseas to get their prices. They might be willing to go overseas to get their drugs, but they don't want their prices from there. So it's unclear whether this is going anywhere, but I want to emphasize also that the administration's not moving very fast on this. They did not actually issue a proposed rule. They issued a notice that they might issue a proposed rule. So don't hold your breath. Now, this rebates idea, I'm using the administration's language. We want to get these backdoor rebates shifted to the consumer. So how does this work? Well, in Part D, we have competing Part D plans. We could call them PBMs just to, again, not have to use too many pieces of jargon. So let's say that it's PBMs and they play the usual role in Part D as in all health insurance. They negotiate prices with manufacturers. They used to negotiate upfront prices, but for many reasons, it has been, the whole industry has moved towards negotiating for rebates, quantity-based rebates. The idea being that the more you sell, the higher the rebate is after the sales period is over. That has raised some issues because people pay their cost sharing typically on the basis of the retail price, not on the negotiated price, which is typically much lower because of rebates. So you're finding people who have very good coverage, but they may have a drug deductible or just a general deductible, and they may be paying a list price for a drug, even a simple drug, that is hundreds of dollars, when in fact the cost to the plan is much lower than that. So somehow shifting these rebates to the pharmacy counter is supposed to lower list prices. And the way they would do this is through changing the rules that make it essentially not protected by law to have rebates, and instead only protect rebates or discounts that show up to the purchaser of the drug at the pharmacy, rather than going through some intermediary process. The CMS actuaries did an estimate on this in August. Interestingly, it was just released. I don't know why. And what they said was, and they haven't changed their view, that the net result is that will increase prescription drug spending, not decrease it. It will increase Medicare spending, not decrease it. And Medicare beneficiaries will save some money, but there will be a redistribution. People who buy prescription drugs will save some money on the drugs, but everybody will pay higher Part D premiums. And the reason for that is that at least some of the money, and we can't say how much, some of the money that comes back to the plans through the PBMs, through rebates, ends up lowering the price of the premium rather than lowering the net price of the drug to the consumer. Now, is that fair or unfair? That's for you to decide. From a business standpoint, if you're running a health plan, you want to increase enrollment. You can increase enrollment by lowering your premiums because people understand that. They have a much harder time understanding, and it really is hard to understand, what am I going to pay for a drug that I'm not sure I'm going to take? So that's the business logic behind it. And what the actuaries are saying is, basically, it's not going to do what you want it to do. So Part D, I'm almost done, believe it or not. Part D reform is needed. And this, I just want to explain something that kind of the basis for why we have to make a change. You know, if you're having a rebate, which is a quantity discount, why does it raise the price? Well, the answer, at least in Medicare, is that above a catastrophic threshold, which this year is $5,100, the taxpayer pays 80% of the costs above that. Beneficiaries pay 5%, by the way, there's no limit on that, and plans pay 15%. Below that, the subsidy for Part D is a capitated subsidy. So you talk about policy schizophrenia. Below $5,100, the plans are getting a capitated subsidy from the government. They have, if we didn't have to worry about the catastrophic threshold and above, they would have a very strong incentive to get the costs of their plan as low as possible. However, you've got this $5,100 threshold, and above that, it's fee for service, all over again. And furthermore, we've had drug developments that increasingly say that it's appropriate for patients to use these innovative drugs that are naturally more expensive, inevitably more expensive. So what we've seen, as Wendell said, I don't think I have a slide on this, is that we've seen this shift towards what is essentially a part of the Part D program that encourages increases in list prices to make room for higher rebates to get more people into the catastrophic zone where there's less responsibility for the plans. It's not a very good structure. Okay, so policy in action, I'm almost done. Oh yeah, that feels better. Okay, so working up to the election, it's pretty obvious. I'm not saying anything you don't already know. The wall strategy will be repeated. The president will ultimately say to almost everything, I don't like that deal. And in many cases, that will make the deal fall apart. Perhaps in a few cases, we might see some kind of change in the deal and something might be saved. But fortunately, we won't have to worry about this disappointment because I don't think there are going to be that many agreements. Maybe a few things on drugs, but I think that's where we are. For me, the big problem here is that the ACA shifted a tremendous amount of power from Congress to the executive branch, particularly through the CMS Innovation Center. That power is not going away. The Trump administration immediately recognized the value of being able to change law without going through Congress, and all future administrations will have the same view unless Congress takes an action, and this is the last 2 years that can happen. So what's on the agenda? You know all these things. I agree with Wendell. What we need to do is prepare for the future. The point that I would emphasize most, especially here in Southern California, is if we're going to make changes and reforms, we need to align the financing with delivery system innovations that emanate from the delivery system, not from the brilliant minds of us geniuses in Washington, because we probably haven't run health plans. We probably haven't seen very many patients. If we did, that was probably a long time ago. And so in the end, Washington can make policies that can facilitate improvements or can make it harder to do. And we haven't been very good at facilitating, but that's what we need to do. Okay, now, this picture is here because it's green. And I just love this picture. But, it also brings up, again, a kind of an obvious political point, which is the Green New Deal, but speaking in healthcare terms, the Medicare for All idea in its many, many forms is pretty much the Republicans' version of repeal and replace. You have your slogan, Medicare for All, repeal and replace, then you get down one level and nobody can agree on anything. We saw this for 2 years for the previous 2 years with the Republicans in Congress. If this got to be serious enough, we might see it at a congressional level, at least in hearings, but we're more likely to see it at a rhetorical level among the many possible candidates. And so what do we have? Well, if you thought this was bad, having this many people on the stage, look at this. Thank you.